but what are the types of workflows or the scenarios in which Carequality is a great solution for integration and interoperability?
Yeah, I mean, it's just, there's a lot of data in those documents. It's document-based exchange, which is very popular, in the last decade. So things like medication reconciliation, med allergy, or drug interaction checking, diagnosis and problem review. So a lot of those things that a physician's practice or another care setting can pull in and just takes away having to ask the patient some of those things and reduces the chance for error.
All right. Hi, everybody. Thanks for joining our webinar. I'm Paige Goodhue with Redox. I do product marketing. I see we've got some folks dropping where they're located in, which is always fun to see. I am based in Madison, Wisconsin, so coming to you from the Dairyland. With me is Brendan Killer. I'll let Brendan do a little intro of himself as well.
Hey, everyone. I'm Brendan Keeler. I'm a product owner here at Redox, having worked with our Carequality product pretty heavily in the past couple months. And I'm out in Portland, Oregon.
All right, so we're almost coast to coast right now. So before we get started, while we're giving folks some time to join, Brendan, I have to ask you a pandemic fashion question, which I know is probably what's burning on everyone's mind. The question is, what is your mask strategy? Do you have a reusable surgical mask? Do you have a plain black mask? I've seen a lot of those. Do you have something that's patterned and kind of fun and a part of your personality? What are you using these days?
I had one of those surgical masks early in the pandemic, but over time I went for one of those charitable masks that have a little bit more, flavor to it. So yeah.
Flair. Yeah. Nice. I also went with something that was patterned for me that I could reuse and wash. So folks want to drop what you're using for your mask strategy. It's kind of a fun way to get to know each other a little bit too. So let's go ahead and start jumping into the meat of our content here. Everyone here is hopefully looking to learn a little bit more about Carequality, because we know that sometimes, especially for folks that are maybe just getting into healthcare or are new to healthcare, they might not be familiar with Carequality. So just starting with kind of orienting on that. At a high level, Carequality is an interoperability framework that connects over 500,000 Carequality enabled physicians to be able to exchange data, which is pretty amazing. Let's unpack what it means when we say that Carequality is a framework. So Brendan, let's hear a little bit about what you've learned with your work in Carequality the past several months.
Yeah, I think before diving into, you'll definitely hear the term interoperability framework used, not network, not HIE or anything along those lines when talking about Carequality. And I think it makes sense to take a step back to talk about why and what it's doing. So Carequality is trying to solve the transfer of care between disparate organizations. So even as there's intense consolidation, these big integrated delivery networks forming across the United States, buying up practices, there's still a limit on the amount that they can move to one system. The United States is never going to have one EHR, one hub system for all of the care. It's just not how we operate. So at some core level, there's need for infrastructure between those care institutions. And those care institutions can vary from, your traditional hospitals and clinics to pharmacies, to labs, to skilled nursing facilities, anything that really where there's a patient touch point. The fire and EMS, they're part of that care coordination and transfer of care. So as an interoperability framework, Carequality gives those tools to connect all those disparate systems and really solve that transition of care. So in order to do so, they don't have this big centralized infrastructure. That's one possible solution to really build a big hub software that everyone connects to. Rather, they've gone for really a disparate trust framework, saying we're going to give the mechanism to list out everyone that is a trusted participant, that is a trusted care organization or technology vendor that can participate in this circle of trust. So by listing out that directory, that's the real centralized piece of infrastructure they offer, is a directory listing that says here are all the organizations that are trusted, that we have proven that they are a part of the patient's care. and then security enforced through what are called mutual TLS certificates. So that's part of Carequality's power and is its simplicity. It's not this big, heavy, centralized piece of technology. It's a lightweight trust framework that once technology vendors onboard and prove that they can meet the standards of, they're able to exchange seamlessly across those participants.
Thanks for that overview. You'd mentioned the directory. I'm curious, just to give folks context. Do you know how many listings are in the directory? Because I know Carequality is constantly onboarding new participants.
Yeah. So right now there's about 17,000 healthcare organizations and different participants listed in the directory. On a weekly basis, that fluctuates, but is trending upwards around 100 or so per week. So there's this consistent growth. And I think with some of the legislation that's coming, what's called the TEFCA legislation, there's going to be more and more incentive for participants ranging from regional health information exchanges, other smaller EHR vendors, so it's really growing at a fast pace, and it's really exciting to see it go from 60% of providers represented nationwide and trending towards 100, and then more disparate care settings like EMS vendors, fire departments, things like that.
Oh, interesting. So now that we kind of have the overview of Carequality, the other thing I want to make sure we talk about, because I feel like they go hand in hand, is Commonwealth. For those of you that have been around health IT for a while, you might remember probably about 10 years ago now, both of them kind of popped up on the scene, both Commonwealth and Carequality. There's a little bit of a hot debate on who was using Commonwealth, who was using Carequality. But those organizations have worked really closely together over the years to drive towards that same function. So for folks that aren't clear on what the difference is, let's just do a quick few minutes on what is Commonwealth and how does it relate to Carequality.
Yeah, for sure. Commonwealth is an organization started in 2013. Multiple vendors participating, Cerner, Meditech, and the core purpose for that transfer of care is very similar. So for sharing clinical documents, they're definitely, their first use case is pretty much the same as Carequality, but their technical solution, the way that's solved through a centralized piece of infrastructure as a national health information exchange, is quite different. What's exciting I think for me to see with the growth of Commonwealth is, yeah, like you mentioned, they've joined Carequality as a Carequality implementer, similar to other regional HIEs that have joined, and also eHealth Exchange, another major national health information exchange. Commonwealth also is now pushing into some of the other use cases beyond just the sharing of clinical documents during treatment. So really adding value as a national health information exchange in different ways. So what it means for everybody who's looking at Carequality is that now that Commonwealth has joined the Carequality network, we're able to seamlessly transfer and exchange data from those sites, and they're able to reach out and transfer data from the sites that are live on Carequality.
Excellent. Thanks for that overview. And I think it looks like we had a question about that already. So Amar, if you have any other questions about Carequality and Commonwealth, feel free to drop those in. If anybody else has questions too, if you haven't found the Ask a Question button, drop those in there, and we'll circle back on those at the end. Hopefully we'll hit on a few of them throughout today's discussion. So I often think of Carequality as a solution that is really replacing that need for faxing in healthcare, which still happens probably way more than most people would be comfortable knowing. But at the heart of it, a lot of these trusted networks really started with the goal of being able to facilitate that provider-to-provider data exchange, knowing that patients can really be seen anywhere and not having to create relationships between every single healthcare organization or physician office around the country. With that in mind, knowing that providers were really who Carequality was first serving, they've started to recognize the need to have software vendors participating over the past several years. So from that perspective of a software vendor, what would you advise that people need to understand about working with Carequality when you're not a provider?
Yeah, great question. to comment on the sort of the fax comparison, I think people often harp and say, why is fax still around? Why is fax still a big part of healthcare in America? Fax is this ultimate ubiquitous tool. It's connected to everywhere. Every practice, every office is going to have it. So in that way, it's this flexible tool that can be used to transfer data. It's really simple, but simple can work in some capacity when it happens to be ubiquitous and can be trusted that you can communicate with anybody. So for these trusted networks like Carequality, they do replace fax in some capacity. When transitions of care happen, fax was that mechanism for sending the patient documents. But Carequality still hasn't reached that same level of ubiquity. And that's what we're trying to solve, is to get it to it where any physician's office, any care setting has that connectivity. And in that way, you can at least strike out that use case from fax. Another difference between fax and Carequality is that fax is inherently a push. You're saying, I have this document, I want to send it to Dr. Page, let me push it over to you via fax. However, Carequality is a pull. So when someone at my care facility gets hit by a bus, I say, oh, I have their identification. I know they've been seen at Sutter Health in California because of their address. I can go and pull that information. So in some ways, it replaces some of those phone calls where I might previously call up Sutter and say, hey, so-and-so has been hit by a bus. I need you to fax their records over. When doing so, so we have this broad access through Carequality. You're getting 17,000 healthcare organizations you can reach and pull that information. But you get sort of a low depth in terms of the transactions available. You have one transaction, the pull of the patient record, which is data dense and contains many pieces of information like allergies, medications, vaccinations, diagnoses. But you're not able to do more fine-grained, event-driven transactions. So that breadth is really powerful and is a really good baseline to start integrating with health systems and to start exchanging data in healthcare. But as you want to go deeper, to write data in a push mechanism, Carequality is not that great of a tool. There are other trusted exchange networks. Direct Trust is a great complement to Carequality, allowing you to push data to any physician, 1.5 million physicians nationwide on this Direct Trust network. So those sort of the yin and the yang of trusted exchange can get you started with a good baseline of pulling data and then being able to communicate in a pretty broad capacity nationwide. Paige, I'm not able to hear you if you're speaking.
Oh, can you hear me now?
Yeah.
Gotta love technology. Awesome. So I think you've touched on some of these, but I think it'd be helpful for everyone to also be able to understand how can a vendor leverage their connection with Carequality. You'd mentioned it's pretty specific to the type of data that is being sent, but what are the types of workflows or the scenarios in which Carequality is a great solution for integration and interoperability?
Yeah, I mean, it's just, there's a lot of data in those documents. It's document-based exchange, which is very popular, in the last decade. So things like medication reconciliation, med allergy, or drug interaction checking, diagnosis and problem review. So a lot of those things that a physician's practice or another care setting can pull in and just takes away having to ask the patient some of those things and reduces the chance for error. Vaccination history, checking their insurance. There's a lot of possibilities with the data that's in those documents. What's important to note, though, is the purpose of use is really defining, is this concept of purpose of use really defines whether or not you're going to be successful or able to use Carequality for your needs. So Carequality is defined as treatment purpose of use, which is anytime that you have a treatment relationship or care coordination. If you're able to pull with that treatment purpose of use, you'll get 100% response from participants on Carequality. However, if you have other purposes of use like payment or operations or research, it's not required right now to respond to those purposes of use. So you'll have a far less of a hit rate in terms of returning documents. With that upcoming legislation, the TEFCA legislation, with the growth of this network, we do expect that over time, additional use cases and purposes of use will be enabled. But for now, treatment is the one that really you'll get that response from everybody on the network. With the interoperability framework.
Yeah, so along those lines, I'd be curious to know, because I think I've seen a few people have asked some questions. Does that mean that Carequality, if you are building a patient health record or a personal health record, a PHR, is Carequality a good use case if you were doing, patient authorized data exchange?
So right now, patient authorized data exchange or patient mediated data exchange is not a treatment purpose of use. That's patient release. Carequality is working on a new FHIR-based implementation guide, just released it actually, to help enable those sorts of transactions using patient credentials and the Smart on FHIR technology. But for now, there's several PHRs like One Record or Azuba that are on Carequality, and they're participating in pulling records where they can, but don't have as high of a return rate, given that many implementers don't respond to patient release. And the main reason, I think I saw a question in there, is that it comes down to there hasn't been a big push to validate that those implementers have proper patient identity enforcements, so that when you're signing up, they're proving that Brendan Keeler is Brendan Keeler and that I'm not someone malicious trying to go and pull my ex's records or something like that. So with these the new implementation guide, those consumer-facing applications will have a better path, have to enforce these patient identity guidelines as a prerequisite to joining the network and pulling.
Okay, thanks for clarifying that. I know that sometimes is what people are looking at Carequality for, so it's helpful to understand the benefits and the limits that you can run into. One other thing with the purposes of use I wanted to ask about is COVID. I know we have a lot of companies that have pivoted to doing COVID care. Is there anything that Carequality has been doing to assist with COVID care in a world where we need as much data about patients as we can?
Yeah, so Carequality has really put some big efforts behind, trying to help in COVID, seeing that they're a major part of infrastructure and exchange nationwide. So they've made exemptions to accelerate the onboarding of public health agencies onto the network, which was an awesome move to really help them collect that data about cases. And then in terms of new implementers, they've waived the requirement to respond to queries, at least for the duration of the pandemic, so that new implementers could get on board and query for information and pull those COVID cases and treat patients. Smaller exceptions, so there's EMS and government agencies, as well as specialty pharmacies, all can participate as query initiator only, given their unique use cases.
Okay. Let's talk a little bit about that concept of query initiator only, because I know from talking with you, and it took me a while to wrap my head around this, is what I like to call Carequality's "you can't be a leech" clause, which is a lot of people I think envision joining Carequality as a way to pull those records, which is what we've talked a lot about. But let's touch on the Carequality requirements for those treatment purpose of use queries. This is an example that you've talked about, just to make sure everyone kind of wraps their head around what does that process look like. Sure.
Sorry, I got distracted by the questions page. Could you restate the question real quickly? Apologies, everyone.
No worries. I was just asking to talk about, we've talked about the ability of using Carequality to get records, but I want to make sure we touch on what does it mean to say that network participants have to respond to those treatment purpose of use, especially from the perspective of a software vendor, because the heart of Carequality is the framework for data exchange.
Sure. Yeah. So query initiator would be outbound saying I have Paige in front of me. I'm providing treatment. I'd like to pull her records from I used to live in San Francisco, from Sutter Health, and I want to look for her records at UCSF. So I send those queries, I initiate those queries outbound. Query responder, in order to send those treatment queries, I also have to list the clinical information I have to the rest of the network. So like you mentioned, it's the don't be a leech clause. It's giving back in a sort of quid pro quo way so that the community is bettered. So if you're providing treatment, you're producing some new clinical data. No matter how specialized your software might be, or your care setting might be, if you're making that claim to be providing treatment, there's something you can give back, and that's a part of the requirements, is to be a query responder, to list those informations in a document-based format so that others can retrieve them when they have to care for the patient.
Yeah, I think that that's something that I know. The reason I had a difficult time wrapping my head around it is I always think from the software vendor's perspective, and so many of our software vendors don't usually develop the ability to receive and respond to queries. So that's why it's always important to understand that before setting up. Which, speaking of setting up, you'd mentioned the onboarding process with Carequality. You've spent the past few months working on that. Would love to kind of hear your take on what that process looked like. Like, what did it mean to get to the point that as Redox, we can say we're connected to Carequality, we can help facilitate data exchange with it?
Yeah. So when you join Carequality as an implementer, there's two concepts. The implementers who have gone through the testing and connectivity process, and then Carequality connections, whether it's underlying hospitals or pharmacies or other care sites that are represented by an implementer. So to become an implementer, it's just like Carequality is pretty decentralized. Their connectivity and testing process is fairly decentralized. You pay a certain fee depending on your size to Carequality, and then you go through and have to test with a certain percentage of the total number of implementers that are live on the network in a testing capacity. So it can be a pretty long and drawn out experience, given that the implementers don't. It's sort of by good nature. They went through the process. They give back to the community, bouncing emails back and forth. And having gone through that process, and also having helped 6 or 7 other new implementers on board, it usually takes 3 or 6 months. So it can be pretty drawn out in order to get live, in order to test all the sort of legacy technologies, the dense XML and SAML and XCPD and XCA transactions. So that's why vendors like Redox offer what we do to sort of simplify that process, to allow other vendors to utilize more modern APIs and technology, just to get up and running without having to necessarily go through the connectivity and testing process.
So would you say that if I'm a software vendor that is looking at Carequality, I have to choose between using a vendor like Redox or doing my own onboarding and certification? Would you say that those are mutually exclusive?
No, I mean, so a vendor like Redox can sort of be white labeled or whitelisted, so that you could, if a vendor wants to have a close relationship with Carequality, to sit on the boards to influence future direction, a customer of Redox's, Point Click Care, did just that. They joined Carequality. They utilized the Redox hardware or software rather in the back end, but were their own implementer and listed their own Carequality connections. Other customers and potential customers want sort of an easier path. They don't need that close relationship with Carequality, so they've chosen to be Redox's Carequality connections. In which case, they can move forward and just join the network, signing the terms and agreements inherent to just signing the simple business agreement of a Carequality connection.
Excellent. And then the last question that I have, then we'll jump into, it looks like we've got quite a few questions that folks have, is if you could go back in the past, so if you had a DeLorean and you could go back into the past to the end of last year, what would you tell yourself about Carequality before starting the onboarding and testing process that you led our development teams through over the past several months?
Sure. Well, if I could go back in time, I'd probably fly over to China and try and stop COVID. But, aside from that, I think the thing that really surprised me about Carequality and isn't something it's necessarily publicized, or is that because it's a decentralized network, because there isn't this hub that maintains some master patient identity across the nation, there's a lot of queries, and that can vary. That inbound traffic that you see varies a lot depending on the geographic regions in the states that you deploy in. So, Los Angeles, with all the dense medical care facilities around there that are live on Carequality, sees 200,000 queries per day or more just for each site that's listed there. Whereas a place like rural Louisiana might be 200 queries per day. So regardless, as you start to scale and list out all your care facilities that you operate at as a vendor, you start to see a ton of inbound traffic. So we've developed and created new technologies and new ways to protect our customers from that volume, so that they don't have to deal with 200,000 queries per day times 15,000 sites. That's millions and billions of queries, which really can add up and be a barrier to entry. Some other things, Carequality is this sort of legacy XML, SAML technologies that are pretty cumbersome to work with. So I think for us, we luckily had support for that, so it was quite easy. I think for new implementers, integrators, it's more of a lift than they expect. So as I help people onboard, I consistently tell them, all right, get ready. If you don't have built-in XCPD and XCA, it's going to be a heck of a journey to go through. So we sort of layer on top, Redox and other implementers layer on top and act for this healthcare data, this built-up infrastructure in a way similar to like Stripe for payments. So for payments, and when you're in the financial industry, you see these legacy networks like ACH or Fedwire that really are actually really old technology. Stripe opened up that whole category of payments to smaller operators, to smaller retailers, with a simple to easy to use API. And that's what we're intending to do with Redox and Carequality, is to open up this powerful network via simple API.
Excellent. Before we go into questions, I just wanted to point out, you might have seen a little button pop up to register for our next webinar. The next one is going to be a little deeper into the technical weeds. So if you're on here and you are a developer or you work closely with your development teams, it might be a good one to join to touch on some of the things Brendan's talking about with the infrastructure we've built that made it a lot easier for us to connect to Carequality. So jumping into the questions, I think the first one we answered and we've touched on, but I think I want to make sure that we've hit on it. So Brendan, the question from Jonathan is, what does Carequality have to say about app developers using it to give their users who are patients a way to access their healthcare, assuming identity proofing has been performed? And I think there was another question just around, what does Carequality do to validate that identity?
Yeah, great question. And we sort of touched on it earlier. So taking a step back, Carequality's first and primary users were providers and other healthcare organization users, because within the context of their enterprise, they're a trusted enterprise, they're a trusted Carequality connection. It could be sort of taken up to the business level to say, as long as they're stating and proving that they're querying from Sutter or querying from University of Pennsylvania or Providence or whomever, they could be assumed to be a trusted user at that organization. When you're talking about patients and patient-facing apps, which are, there's incredible growth there with things like Livongo or, personal health records. Carequality's first and baseline isn't really built out for that. They allow for the purpose of use of patient release of information. However, they don't have in their current implementation guide a lot of guidance about how to prove Brennan Keeler is Brennan Keeler. And there's a lot of ways in the industry to do so. If you go through Experian or any other process, they prove it with all those knowledge-based questions. There's big efforts in the industry to improve that. Knowledge-based questions are not a great way, or not a pleasant user experience. So the Smart on Fire technologies that ONC Cures legislation have pushed forward open up and mean that every health system has to list out FHIR-based endpoints for pulling discrete US CDI data, the US core data set. Carequality is along with the Care and Alliance is layering on top of that with their new implementation guide to say you must prove the patient's identity through X, Y, and Z. There's NIST and all these standards we could get into and spend a lot of time on. But once you do, you can use this dynamic app registration with all the FHIR endpoints listed in the Carequality directory. So there aren't any yet, but that's coming, and that's the next wave of really opening up and being able to pull that EHR data for consumer-facing application purposes. So I'm really excited by the ONC Cures, by what Carequality and Karen are doing, simply because patients and consumers have not been empowered in the same way that you have in finance or something, where you have Mint, where these killer applications were developed a decade or two ago, and now it's pretty well developed and seen just omnipresent through lending processes and things like that. But now with all these technologies, we're going to see a big growth in consumer-facing applications in a way that just wasn't possible 10 years ago.
Okay, great, thanks. Our next question from Peter is, now that Carequality and Commonwealth work together, can the record locator service be used by Carequality participants?
Yeah, great question. So as part of joining Carequality, Commonwealth did say that they'd be listing their centralized infrastructure as a record locator service. So taking a step back, how do you find a patient on Carequality is a good question. Searching, when I can go and search anyone on the network, but there's 17,000 nodes, each with their own patient database. So if I send a query out to UW near Page, they'll use their algorithms and they'll say, you provided these demographics, and I found the patient, or I didn't find the patient. So it's decentralized, that patient identification process. As you scale that out, as this network grows, it becomes completely unwieldy to query every, and it's really bad practice to query every node for every single patient you see. So you see implementers start to use algorithms based on geographic radius and zip code. A record locator service uses existing data stores to identify and provide back to implementers where those patients might be, where they've been seen. SureScripts has historically offered the only record locator service on Carequality. Commonwealth has been working on, but still has not released their record locator service for use. Redox is working on record location services for our customers. So we're expecting, right now, we offer those sort of direct searches and across the network and the directed queries, but are hoping to help solve that problem for our customers of simplifying and saying, here's where Page has been seen nationwide, given the data we have access to.
Excellent. All right, our next one. So because we've talked a lot about Carequality supporting providers, I think that's where this question is coming from, is do we have to be a care organization like a clinic or a hospital, a physician, to connect to Carequality? What about healthcare IT product development folks?
Yeah, what's really exciting about Carequality is it's not the healthcare organizations that sign up and become implementers at all. It's actually a health IT vendors. If you look at the list of organizations, it's EHR vendors like Epic and Cerner. It's vendors like Redox or InterSystems. So we sign up and we go through that process and then can scale across different sites. So if you're working as a health IT vendor, you're making some software. You can join and connect through Redox or through directly if you go through that process. And then as you sell to hospitals or as you sell to care sites or anywhere, you would just list those care sites appropriately in the directory. So yeah, it gives you a self-service way that as you sell your software, as you deploy nationwide, you can easily onboard your customers.
Yeah, it becomes an option too if you are working with a healthcare organization that has difficulty making their clinical summaries available in other ways. They can point you to using Carequality as a way to get that, which is a handy back pocket option to have. All right, our next question. Are the documents typically using the CCDA format, or is it some other type of format?
Yeah, it's a great question. Yep, most of the documents on the network are CCDA documents today. So with Redox, we can offer back those dense XML documents sort of as they're sent, or we also have a JSON API to make it a little simpler if people prefer that format of data. Like I mentioned, in the future, we're definitely expecting to see a push towards FHIR, so more lightweight, resource-oriented API. But the current legacy architecture is mostly CCDA documents with a little mixture of PDFs, especially in the Commonwealth network.
Okay, thanks for that question, Patricia. Our next one is from Adam. Any insights into how does the data from Carequality appear in the EHR for a provider to view? Recognizing it varies by EHR, but kind of at a high level, what does it look like for a provider to consume from a software vendor?
Yeah, so the simplest way to implement sort of a view from the data retrieved is to just use standardly available public templates for CCDA. CCDA as a document it's not like a PDF. It's not just all human readable content. It's discrete content and human readable content, which is advantageous because it can quickly be rendered through those CCDA templates, or it can be discretely parsed and pulled into the chart. So your simplest view is, and you're going to see that we can send it out afterwards, the sort of ONC and government released version of the templates, but it's a purple and blue view on this data that haunts my nightmares a little bit. But beyond that, advanced software vendors take that information and put it contextually, not as a separate, let me look at this document, but as part of the chart. So they show it side by side with the data that they have. So if you look at like an Epic or something like that, they have great functionality because they've been doing this as long as anybody to really embed that in the workflow. UCSF did a great study about just when they turned on that feature, how much more the doctors used and utilized that data. It jumped by like 10 or 15%, which is really great to see how they reference that outside data when it's built into their workflow.
Awesome. And with that outside data, I know at least with Epic, there's often a step. There's the step to view it, and then the step to pull it and formally add it to the record. So they're most EHRs are making it easier for providers to find it, for having it integrated into the patient's medical record. There's often another step that they're taking to do that once they've validated that the data looks correct.
Yeah, especially for some of the patient level data, for the medications, the allergies, the problems. If you just pull everything in, it's going to probably be duplicative either with things you've already inputted or as you pull from different sources. Because Brendan Keeler, if I have diabetes, when I pull from Sutter, when I pull from UCSF, it's going to show up as a problem on my list for both of them. But in actuality, it's one problem for me. It's not 5 copies of diabetes.
Yes. All right. Our next question from Fred is, does population health or an analysis of a group of patients count as treatment? And then the second part is there a framework for a bigger pull with patient auth for population health from a health plan or insurer?
Yeah, there's a couple questions layered in there, but first, so population health, sort of care coordination by, let's say, an ACO can be part of treatment. You're trying to maintain that treatment plan over the course of caring for that patient in a broader sense. So you see ACOs that run on some of the Epic softwares and other softwares definitely pulling for that care coordination, which is sort of a subset of treatment. In terms of pulling populations, Carequality doesn't support that. You're sending and saying with each query, here are the demographics for page, or their name or date of birth, etc. And then they respond saying whether or not they have that. It's not a way of bulk saying, let me have every patient that has diabetes or something like that. It's just, that's not how, because it's been designed for that transition of care of a single patient. That's how it functions today.
Our next question from Zach is, how long does testing and onboarding take when utilizing a partner like Redox? Or phrased in another way, what's that reduction in onboarding time look like?
Yeah, it's as quickly as you can program up to our APIs. They're pretty simple to use. We've had people do it in a couple of weeks. So you're going from 3, 6, 9 months, depending on how quickly you can wrangle all the implementers, to a lot quicker and easier experience.
Awesome. And if you're already coded up to the Redox API, what does that time look like?
Yeah, I mean, then we can get you connected to the sandbox today, and you can start playing with some of the sandbox data. So,
awesome.
Yeah, anyone who's interested, definitely reach out about that, and we can get you testing and seeing what data exchange like Carequality looks like in a staging environment.
Excellent. And that is a good note that there is a Carequality sandbox. So for folks that are thinking about this, whether you go the route of using a vendor like Redox or doing the self-process, that sandbox can be helpful to make sure you'll get what you expect from it. Our next question from Matthew, we touched on this a little bit in one of our earlier questions, Brendan, but I think it's worth just circling back on is, how does Carequality compare to query-based exchange or directed exchange? So kind of where does it fit in the continuum of that?
I mean, it's both of those things. You have this broad access that you are doing query-based exchange. You're sending out a query or being sent a query and responding with first, that patient search, and then the search for documents. So it's definitely part of the query-based exchange. The implementation guide is called the Carequality Query-Based Exchange Implementation Guide. And then it's directed. It's not a hub software, like we mentioned earlier. It's not an HIE where you're saying, let me send a single query to the HIE and have them respond on behalf of all participants. You're saying, let me query Sutter, let me query Houston Methodist, and then they respond individually. So that's how it works.
Excellent. All right. So Malvika asked, how can a digital health or digital therapeutic organization work with Carequality?
Yeah, great question. So there's plenty of digital health and therapeutics companies already on Carequality today. Thinking if you like Virta Health, does diabetes management. They're certainly participating and pulling and being pulled from, as they are that treatment purpose of use. So it comes back full circle to, are you providing treatment? How are you providing treatment? And what clinical data can you list back for others to pull as you join? So yeah, that's how you, as long as you're providing treatment to the patient, you're going to be able to be successful with Carequality.
Okay. And we have another question from Patricia around the information blocking rule. So with the new information blocking rule from the ONC, will implementers have to respond for payment and operations purposes? So basically, do we expect that rule will increase the likelihood that participants will respond to other purposes of use?
I think, so the data blocking provisions in the ONC cures really is going to open up a lot of that patient authorized exchange. It's going to open it, also really bring down the barrier to entry on app exchanges. So if you're trying to join Epic App Orchard or Cerner Code, you're going to see a lot less friction and cost there. When it comes to sort of these organization to organization trusted network exchange, the TEFCA legislation is what's really driving the growth here. And the Carequality as part of the Sequoia project the Sequoia project was appointed the recognized coordinating entity for TEFCA, and meaning that they have a lot of jurisdiction to define how organizational exchange is going to really grow in the next 10 years. So I think it's part of that, unless the data blocking provisions, that we'll see more growth for payment and operations. We do have Carequality connections joining for payment operations, patient release of information today. And I think it's largely because they want to be part of that conversation to help drive it. So for the Carequality connections that do respond, they want to be pulling that information.
Excellent. We've got another question from Adam around, are there any standard requirements for format in which treatment information must be shared back with Carequality in order to participate? So what's the format when you're responding to those queries that needs to be used?
Yeah, so it's not really strongly dictated in format, but CCDA is the status quo. So encoding that data into the continuity of care document, either if you're doing it yourself, that XML, creating that XML document, or if you're using Redox, you can either pass us the XML or use our JSON API, which you can selectively choose the elements that pertain to you. So thinking about what's in there, it's the medications, the allergies, the problems. So if you're doing something along those lines, those are easy to list. But even just clinical notes embedded in the CCDA document are pretty commonly a piece of data that someone might list.
Excellent. Elizabeth, I think that we got your question answered about whether or not Carequality has a provider-facing UX and what type of UX is typically piping the data. It'll be dependent on what the EHR vendor is displaying. Since Carequality is a framework, they're not really in the business of rendering the documents, but making sure that they can get where they need to go. If that doesn't answer your question, feel free to drop another follow-up one in. Go ahead.
Just to quickly jump on that. So Redox gives these simple APIs to development vendors so that they can embed this data into their UI, or the UX rather. Carequality doesn't offer that, that provider-facing view, and Redox doesn't either. We offer that simple API so that technology vendors can easily add this information and tailor it to their workflows.
Mm-hmm. Excellent. Our next question is from Matt. Is Carequality being used to support quality metric reporting and registry creation use cases at this point?
So there are Carequality implementers that are focused on advancing that sort of use case and purpose of use. It's not heavily used in that way, given that it's not strictly treatment. The other thing that's happened in the past couple of months is the electronic case reporting. So as COVID has grown a lot, Carequality has defined, using the trust framework, how hospitals and other care facilities can report to public health agencies the cases through the passing of the CCDA document. So today, that's the extent of it. We don't see a ton of registries pulling these CCDA documents, again, because of that purpose of use, restricting their ability because they're not necessarily providing treatment.
Okay. Our next question is from Brian. How is semantic interoperability validated and updated across 17,000 members, particularly as new clinical research and treatment performance data becomes available and best practices can change?
Yeah, it's a great question. So the CCDA format, like any standard, has a little bit of flexibility in what can be included and how to encode it. So Carequality has a data quality work group that is consistently working on recommendations and requirements to ensure that the way that this is presented, the information is parsable, understandable, and can be embedded without really any extra lifting. So that data quality work group is putting out an implementation guide that's going to be required in the future.
Okay. And from Noel, what is the biggest difference between Carequality and a regional HIE? And how does the information provided through Carequality compare to that of a regional HIE or any sort of HIE?
Yeah, great question. So regional HIEs coming out of sort of the meaningful use are really popped up all over the country. There's currently around like 75 regional HIEs, some statewide, some at even a more granular level. They vary a ton in terms of the business agreement. That one state may have a very different set of business agreements than another state, and also in capabilities. So some are really well funded, are really verbose, and able to do a lot of different functionalities. So regional HIEs can be, if you're focused in a certain geographic region, exploring what they can offer is really valuable. Redox is connected to 16 or 17 regional HIEs in different capacities already. But the functionalities that they offer, they're not necessarily just query-based exchange. It could be, clinical reporting or lab reporting or all sorts of other functions. And actual regional HIEs are actually trying to differentiate themselves today because they want to stay relevant. They want to be offering different, capabilities to their members.
Okay. And we have two more questions and we'll have to cut it off after then because we're getting close to the top of the hour. So from Bruce, and this is in the chat, is behavioral health utilizing Carequality? And he mentions that consent in particular has been an issue in the past for organizations that they've worked with in. I'm assuming NH is referencing New Hampshire.
Yeah, it's a great question. So it's up to the implementer and more specifically the Carequality connection to collect consent to release documents and in the way that's abiding by local legislation. So when I query, Sutter in California, they typically have an opt-out policy. So most patients, they'll have already consented as part of their standard HIPAA consents. But if you go to like Minneapolis and Minnesota, which I believe is one of the more restrictive consent laws, a lot more opt-in type of consents before information is released. So if I query somewhere in Minnesota, I may get back a patient not found when really they exist in that EHR, but have not consented. In regards to behavioral health, you'll often see many of the implementers just omitting the behavioral health information because of the more restrictive consent policies. But that's something that implementers are working on, is how to collect consent in such a way that they can release behavioral health information in a safe and legal way.
Okay. And our last question is from Muthu. Does Carequality or Redox have a basically way to take documents that are faxed or unstructured data and put it into a CCDA format?
That's a good question. I think we would typically rely on outside NLP vendors of your choice to push in that information and parse it back out. So Amazon Web Services or with Comprehend Medical or other ones that offer sort of APIs. So would love to talk with you in more detail about what you're looking for there and how we might be able to plug you into some of those services.
Okay. Excellent. Well, thanks everybody for joining. If you are interested in chatting with Redox about Carequality, you can reach out to hello@redoxengine.com or jump on our website, redoxengine.com, and you'll be able to find an option to reach out to our team. If you're interested in kind of digging a little bit more into the underpinnings of integration infrastructure and what does it look like to have something that can scale, use the green register button at the bottom of your screen to sign up for our next webinar, which will be done with one of our development tech leads, Tristan Wilkinson. So thanks everybody for joining.
Thank you, everyone.